Glad you're all back this afternoon. Hope you had a chance to have some good lunch with some new friends or some old friends, either way. We're going to jump back into our discussion. I would also like to welcome back the people that are on our webinar, so the viewers that are there, thank you for joining us. Now back to our discussion. Our panel this afternoon covers information on the Medi-Cal Managed Care Plans. And we have the following three presenters with us. We have Norma Duran, we have Maria I'm not going to pronounce it correct. Calleros, thank you. And so Norma is from WellPoint. Maria is the Director of Safety Net Initiatives at LIHP Plan. And we have Elizabeth Gibboney, and she's the Deputy Executive Director and COO at the Partnership Health Plan of California. So Norma is the account manager at Anthem's Medicaid business and is responsible for overseeing the accounting management functions of Anthem's Medicaid business in California, such as Healthy Families, AIM, and the County Medical Services Program. Ms. Duran has 18 years of experience with the managed care, including extensive experience in strategic alliances, provider network relations, managed care regulatory compliance, health plan operations, and medical group management. Maria is Director of Safety Net Initiative at LA Care Health Plan, the largest public Medi-Cal plan in the United States with over 1 million enrolled members. In this role, she oversees the strategic initiatives and partnerships between LA Care and Safety Net, providers throughout Los Angeles County to improve operational efficiency and prepare for implementation of the Affordable Care Act. Maria has over 20 years of experience in the managed care operations administration of public health programs. Elizabeth Gibbons is the Deputy Executive Director, Chief Operating Officer at Partnership Health Plan of California in Fairfield. Liz is responsible for plan operations, which includes member services, provider relations, claim healthcare services related to care coordination. She also oversees the Partnership Regional Office and is board president of Aldea Children and Family Services, a foster care mental health provider in the Napa Solano area. And she has a fellowship with the America's Health Institute insurance programs. She is a graduate of the University of California of Davis and California State University. And we also ask that you hold your questions till the end of this session. Go right ahead.
Good afternoon, and thank you for allowing me the opportunity to speak at today's conference. Anthem is very interested to collaborate and hear comments from you, so I'm very looking forward to the question and answer after our presentations. Some of the things I would like to cover is just to kind of provide you a little bit about Anthem Blue Cross, discuss about our commitment in the community, care management and disease management programs. For continuity of care and initial health assessment, I just will provide you some brief information on that, with the understanding that our internal teams are still looking at the transition plan and looking and comparing what we currently do now and what changes we can make. So at this point, it's just currently part of our internal process that I'll be sharing with you. I'll also be sharing you some of our telemedicine capacities, as well as our network of providers and some of our process. I'm very proud. Our company is one of the largest national companies that provides managed care. In California, Anthem Blue Cross serves more California state products than any other plan. Today, we provide coverage for eligible families for state assistant health programs such as Medi-Cal, RSPD, Healthy Families, AIM, Mr. MIB, Path to Health, CMSP, and California Kids. Anthem has been serving Medi-Cal members since 1994. We did introduce telemedicine as a solution to address rural healthcare issues. We are the plan administrator for the CMSP governing board since 2005 and effectively launched the Path to Health low-income health program in 35 counties in 2012. I do want to highlight that out of the 52 low-income health counties that we're currently operating as a plan subcontractor in 9 of those counties, and 18 of those counties we are currently gearing up as part of the rural expansion, so we're hoping that we can expand managed care in those communities. You know, our programs are focused on our members. We recognize the uniqueness of the population that we serve. We provide customized approaches to a care, identify and provide early interventions for our high-risk members, and support medical home of our members. With that said, you know, with the expansion and just understanding some of these communities, we are identifying that each county operates a little bit different, and the needs of each community is different. So we're really trying to collaborate with community-based organizations, providers, to ensuring that we understand those needs and are meeting them. Our community partnerships are really the foundation. We understand the importance of the traditional safety net providers, so we definitely are in discussions with them to making sure that they're part of our network and they provide us information of that membership that we need to make sure that we can address. You know, managed care really allows us a system of care aimed to creating healthier membership. We focus on preventive care. We look to afford members a medical home with a provider that they know and they're comfortable with. We provide education and care management, you know, as part of our cornerstone. We treat the member as a whole. And we still want to make sure that the doctor feels that they're in charge of the member's care, that the members feel comfortable and the doctor is really the one that's directing the care for that member. As I mentioned kind of earlier, you know, we are trying to engage with our community at the county level with our county services, our community-based and faith-based organizations, and we try to do that by attending healthcare events, collaboration, and we are also looking at establishing stakeholder engagement groups. Anthem partners with the counties to promote public health programs and train providers. Supporting community partnership is what we do to help ensure services are available through a holistic care of our members. Servicing our members comes in different components. You know, our outreach is one of the staff is the staff that's directing and in contact with our members. We provide preventive health care services notices, emergency room education. We help with scheduling appointments. We have a 24-hour nurse hotline. We do provide new member education, and we ensure that they have referrals to our community-based organizations. We understand transportation is very critical. We are currently working with Logistic Care Solutions as our transportation vendor and looking at areas that they can expand to provide services in those rural communities. We have our customer service line, and we have health education and cultural linguistic programs that are available to our members. Our member intervention programs focus on specific quality measures across the state. It includes interventions that may be outgoing calls, some member incentives, provider incentives. We make sure our mailing is done, and we also focus on high-risk members. We try to utilize data from claims, pharmacy, that will help us identify those high-risk members. We try to conduct home visits, telephonic interventions, and provider communication. One of the biggest things that we've learned, you know, through our lessons with the SPD in calling some of these members, they're sometimes very difficult to reach. They have challenging needs. Sometimes they're homeless. And at times, you know, by us calling, they're still kind of hesitant to even speak to us. So I think that kind of really emphasizes the importance of establishing a communication and great relationships with the providers, because that's who the members are comfortable with. So we want to make sure that we're creating great partnerships not only with our providers, but also with the community-based organizations and advocates. Here's just a quick chart of some of the wellness programs that we offer. We look at services to help members to get well. We utilize e-census, emergency census. Clinical teams support coordinating care when patients are admitted or are leaving the hospital to ensure PCP appointments and medications are met. We have disease management programs around chronic disease such as diabetes, smoking cessation, just to name a few. Our health assessment with members when they get enrolled who are high risk or for SPD. We have member interventions with home visits when needed. And we work with home health and community organizations to ensure the ability to reach out to the members. And again, some of the information we're reaching out and in our discussion is that how do we get that information and ensuring that the providers have the information, you know, and not just sending it to the members. You know, here's a slide with just the definition of continuity of care. I think the importance here is that we try to meet our contractual agreements with the state. The state does have requirements, and we work very hard to making sure that we're meeting the needs of the members through our coordination of continuity of care and access to care. We are responsible for providing access to care and coordination for medically necessary services to our enrolled members. Part of that effort and the collaboration includes the utilization data that we get for managing the members' care, medical staff, primary care providers, and other professionals who have an active role in managing the members' health care conditions and needs. Obtaining the data sometimes can be challenging, so what we identified is our providers are very active in reaching out to us and collaborating with us. And we want to make sure we also extend that collaboration with other providers and community-based organizations. So they're very proactive. That's one of the things that we've identified. So it helps us to making sure that the member is getting the care. Our standard process includes, but it's not limited, that we make sure that every new enrollee gets the rights to request continuity of care, that they understand it. We have our utilization management team that completes a case intake. And anything that we also identify, so if they've been continuing care with a provider, we make sure that that the provider doesn't have any sanctions applied to them. And if needed, we'll refer the member appropriately and making sure that the member is engaged. And we want to make sure that the member is also part of the driver as far as coordinating their care and making those decisions that they feel are right for them. Our providers help to ensure continuity and coordination, care through collaboration. This includes information exchanges between primary care specialists as well as behavioral health. In addition, Anthem helps coordinate care when the provider contract has been discontinued to help a smooth transition to a new provider. We require providers to accurately and timely document in their medical records any consultations, prior authorizations, referrals to specialists, and treatment plans, so that if a member needs to transition and have some coordination care, we have that information easily available. Our continuity of care and continued access to care, our utilization department, really our nurse staff, is really good about developing a transition plan for the member. The plan includes a treatment plan by the non-participating provider. It does describe and does document the member's progress. It does list specific treatment goals that we're trying to meet. And then we also look to see if there's opportunities to refer the members to Anthem's Medicaid resources. At times, our contracting staff will also work with our access to care nurses to ensure if there's opportunities to contract that provider and bring them in network. A lot of times providers are a little hesitant. They normally don't service this population. Sometimes they'll start off with a letter of an agreement, and then once they come a little bit more comfortable, they'll go ahead and sign an agreement with us. So we definitely take that opportunity to have our access to care department and our contracting team work very good together. Our goal is to really provide quality health care right to the member at the right time in the appropriate setting. And to achieve this, again, it's the collaboration with the primary care physician, specialists, ancillary providers. We do lean in their extensive healthcare education and experience and we rely on their dedication to our members, and we look to them to ensure that the member stays well. Our initial health assessment, and again, we're still looking at the LIHP transition plan to see how we can make some changes, but currently the comprehensive assessment is completed during the member's initial enrollment and must be documented in the member's record. The initial health assessment does include a health assessment and a physical examination, a developmental assessment, and a health education behavioral assessment. Our initial timeline for members 18 months and older is within 120 days from enrollment. We do inform all of our members the importance of scheduling an appointment for their initial health assessment. And so we do some outreach. We do send some postcards to ensure that the members are informed of the importance of it. We also encourage our primary care physician by supplying them a list of new enrollees to them, so that they can also be proactive in reaching out to the members and scheduling an appointment for their health assessment. The primary care physician, once they conduct that assessment, is also responsible for ensuring that any follow-up services are available and to the member within 60 days. We work very strongly or closely with our case managers who develop individual plans to care for the members' coordinated care with chronic and complex conditions to make sure we maximize the members' benefits. And we also conduct some internal monitoring to making sure that we are meeting the requirements for the initial health assessments as stipulated by the state. With regards to our network, here's a snapshot of our telemedicine network. We now have about 67 presentation sites. I know it says 62, but we are continuing to try to extend our telemedicine network. 3 additional sites are currently in development that will be supporting El Dorado, Calleros, and Sutter County. I think that telemedicine is important, allowing the providers to connect in the community. It improves access in the rural communities, makes seeking specialties locally available. It offers convenience for the specialists and provides medically services locally. It supports local healthcare infrastructure by keeping healthcare spending in the community and enables the patient to be diagnosed sooner. Additional benefits for our non-clinical applications include training, continuing medical education and college coursework, supports group, and administrative conferences that we provide. Our statewide network consists of 24,000 physicians and clinics, approximately 200 hospitals. We have agreements with academic medical centers and centers of excellence through the state for complex referrals. We have various contracting models available depending on the provider's interest, ranging from fee-for-service to capitation. Our network staff knows California, the medical product, and providers, including providers in the rural areas. With expansion, one of the things that we are offering is, any letters of intent when a provider is interested to become contracted and just start the process. It's a non-binding document, but it starts the process if they're showing some interest. We send them a contract package that includes the agreement and also some credentialing information. There's no risk, there's no commitment. Once the document is signed from the provider, then we start the facility site review and the credentialing process. With expansion and the LIHP expansion and understanding the development of a network, we utilized our CMSP network, our Healthy Family Network, and we're also targeting some of our commercial network. And the state also provided us a list of providers that have historically serviced this population. And so we're really looking at any provider that is interested that's contracting, we're reaching out to them. Providers can terminate their contract at any time. There's no lock-in period. And with that, I thank you for your time and look forward to the question and answer.
Great. Thank you, Norma. Okay, good afternoon, everybody. So I am Maria Calleros, Director of Safety Net Initiatives at LIHP HealthPlan, and honored to be here and be part of this exciting effort of being able to actually be part of this historic opportunity to move a lot of folks into Medi-Cal with the flip of a switch. But as we know, there's a lot of details that need to support that flipping of that switch. So today what I wanted to go over is just kind of set context to tell you a little bit about who LIHP HealthPlan is, share with you some information about what we've been doing locally to plan around this transition, and then share with you some of the ideas we have and work that we're doing around getting ready for this transition. So so about LIHP HealthPlan. So we are in Los Angeles County, as many of you know. We were established in the early 90s and went live as a health plan into full operations in 1997 to serve as the public health plan in LA as part of the two-plan model. And our mission is to provide Medi-Cal services to low-income populations, to Medi-Cal beneficiaries, as well as to serve other low-income populations. And as a public agency, we consider ourselves community accountable and definitely invested in supporting the safety net provider community. We currently serve 1.2 million members, of which most of that population are Medi-Cal beneficiaries. We have 1.1 million members in our program today under Medi-Cal. So that's a large population, and we are expecting, again, a large number of members to transition into the Medi-Cal program come January 1st, of which a subset we will be coming to LIHP. A little bit about our provider network model. We contract, we have a hybrid model here. We contract not only with 3 Knox-Keene licensed plans, but we also contract with over 36 private medical groups. We also contract with our local county Department of Health Services public hospital system, which is comprised of 23 different clinic sites, 4 hospitals. And we also contract with many community clinics. In addition, we also have contracts with the private hospital community, as well as hundreds of contracts with various ancillary providers. So we have a very broad network. All right, a little bit about our local planning efforts. So given that Los Angeles County, the Department of Health Services, who administers the local LIHP program, given that they've done such a fabulous job of enrolling and at this point have about 250,000 individuals enrolled in the LIHP, we felt early on in 2013 that there was a need to really start engaging in discussions with not only the County Department of Health Services, but also the community clinics who are part of that network. With the potential to have 250,000 members flip into Medi-Cal Managed Care on January 1, we knew that careful planning would be required in order to mitigate disruption in their care. And so we convened in February and late March and formed a couple of work groups with the following goals. The goals being to ensure members have seamless transition without experiencing gap in coverage, optimizing the ability for us to preserve member PCP relationships if that was the member's choice, and of course assure continuity of care protections and ensuring that those would be in place in order to, again, mitigate any disruptions in care. And the areas that we have been focusing on have been member education and outreach, the member clinic home primary care provider data exchange flow process and how that's going to work, talking about member projections and what we might expect in terms of real numbers come January, as well as looking at our provider networks and seeing where there's gaps and overlaps, and also looking at provider contracting strategies to facilitate continuity of care come January 1st. So that's been the focus of our local planning efforts. What we've been doing at the health plan level is we have an internal work group that is focused on getting ready for the LIHP transition. And our work, I'm going to say, has focused around 3 buckets. First of all, proactive care transition planning. What are we going to do to get ready to ensure there's careful transitions of care for this population? Looking at our provider network and ensuring that it's adequate, as well as developing strategies around provider outreach and training. Because we know that if our provider community is not ready and informed, again, that will contribute to some potential disruptions in care. So those are the 3 areas that we're focusing on. And the next slide is basically a diagram to show you kind of the conceptual model of how we see making this transition work almost, I want to say seamlessly, because we want to shoot for as seamless as a transition as possible. So the concept is that we will be able to obtain information from our state and county partners related to utilization experience, as well as current open services that are being, authorizations for services that are currently in the flow, as well as getting the medical home information, and using these 2 pieces of information to really conduct a lot of mining and analyzing of this data to help inform the various critical business operations that need to occur in order to make this seamless. By processing, for example, all the clinic home data, what that will enable us to do is to connect the member to the appropriate clinic home. Our concern and focus in terms of member connection is really around those members that don't make a plan choice or don't take an active, an action as part of the period they have to select a health plan. So our focus is going to be on those that will then kind of end up defaulting, if you will, and being required to be linked to their clinic home. In order for us to be able to do that successfully, we need to make sure that we have the appropriate clinic home data from the state and our county partner, and that's not just getting the name, but getting the appropriate provider identifiers and making sure that there's matches there. In terms of transitional care, I'm going to flip here. In terms of or actually, let me come back to the member connection. And some of the things that we're doing currently with our county partner to get ready for this clinic home assignment activity is we've been engaged in work sessions to map out the process of how members come into the LIHP program today, how they get assigned a clinic home, what are those identifiers that are used in that process, how that information is being communicated to UCLA, and how it'll flow over to the state and therefore us. And then internally, we're doing the prep work to make sure that those provider clinic identifiers that will be shared with us are registered in our system so that there is a match once we receive the data. The other things that we've been looking at is mapping out the timeframes that, based on the current state framework of passing eligibility files to us, we are trying to map out and forecast if those timelines will work. There may be a need for us to try to get data sooner